Welcome all to the TB Think Tank webinar, where we are showcasing the Union Conference presentations. And this afternoon, we have 4 presentations, right, with 4 presenters. And all questions will be at the end of the session so that we can allow all presenters sufficient time. Firstly, we have Ms. Nelly Jinga. Ms. Nelly Jinga is an epidemiology researcher at HERO. She also contributes her expertise as a researcher to the TB Sequel Project Socioeconomic Research Task. Nelly holds an MPhil degree in demography from the University of Cape Town, further enhancing her research capabilities with ongoing PhD studies at Wits. Her academic journey lays a solid foundation for her specialization in epidemiological research. Her scholarly work demonstrates her commitment to advancing research in health services and patient care within the context of HIV and TB. Over to you, Nelly.
Thank you. Thanks so much, Nolazi. So today, let me just share my screen. Okay, are we good there, Nolazi?
Yes, we are, Nelly.
Okay, thank you so much. So I'm going to present to you some of the work we presented at the TB Science at the TB Union this year. So this analysis piece is titled Long-Term Impact of Pulmonary TB on Health-Related Functioning and Well-Being in 4 African countries. So for many TB survivors, they continue to experience the physical, psychological, and socioeconomic morbidity long after TB treatment. So we see that there are over 10 million incident cases of TB each year, and over 85% of TB patients successfully complete TB treatment. But TB survivors continue to experience these challenges that I mentioned before, long after treatment completion. Although there is some recovery over time, a minority of TB survivors continue to experience these challenges. So looking at the long-term effects of pulmonary TB, there's the psychological consequences, which includes mental health issues and social stigma. There's also the physical consequences, which include persistent lung problems and reduced capacity to exercise or to do strenuous work. There's also the economic impact, that's usually caused by deserving, taking loans during the treatment phase and even before diagnosis. And this put a financial strain on individuals and families. There's also overall quality of life, which is reduced across life domains. So this study, this analysis is based on a study called TB Sequel, which is a multi-country prospective observational study that was done in 4 African countries. And this study was done in 2 phases. The first one was from 2017 to 2022. And the second one, which is currently ongoing, was from 2023, and it will run until 2027. And this was a cohort of TB patients and survivors that were followed up from diagnosis to 8 to 10 years. So from phase 1, that was from 2017 to 2022, we found that 15% of participants continued to experience psychological distress after completing TB treatment. So recognizing the ongoing social, psychological, and the economic challenges faced by TB survivors, this phase 2 leverages on the existing TB sequel cohort to conduct a unique prospective analysis of long-term psychological, economic, and social challenges with a specific focus on health-related quality of life. So this takes us to our objective, which is to describe health-related quality of life, physical functioning, and well-being in TB survivors 4 to 7 years after completing TB treatment. So So phase 2 of the study, which this analysis is based on, was conducted between June 2023 and July 2024 among adults who are 18 years or older who had completed their treatment for pulmonary TB between April 2018 and July 2020. So we collected data using 3 validated instruments. And the first one was the short form, the SF12 questionnaire, which is a questionnaire with 12 questions and 8 domains, and it scores from 0 to 100. And a higher score means better health-related quality of life. So we calculated our mean scores for the physical and mental component scores. And we also use the Kessler Psychological Distress Scale, the K10, which measures general psychological distress, which is useful for screening and monitoring distress over time. And in using this scale, higher score means greater distress. So we categorize the scores into less than 20 that we defined as normal, 20 to 24 we defined it as mild distress, 25 to 29 we defined as moderate distress, greater than 30 as severe distress. We also use the Sheehan Disability Scale, which assesses the impact on social work and family life. And we categorize the scores as 0 to 3, we defined as none or little, 4 to 6 moderate, and 7 to 10 severe. We also asked the participants to what extent has TB affected the household financially. From 1 to 5, 1 to 2 we defined as no or little impact, 3 is moderate, 4 to 5 is severe or very severe. And we also looked at the demographic and clinical characteristics. We stratified our results by time since TB treatment completion, and we had 2 groups, those who finished 4 to 5 years and those 6 to 7 years. And we did group comparisons using students' TB test. Now moving on to our results, we analyzed data on 655 patients with mean age 36.3 and 62% of our sample were male. Now looking at the health-related quality of life results, we see that the mean physical component scores for the group 4 to 5 years is higher than the 6 to 7 years group, which means the 4 to 5 years group had a better health-related quality of life. So the reason why health-related quality of life for the 6 to 7 years group was poor, we attributed maybe to the progressive decline in lung function, to reinfection or relapse, or other comorbidities. So I just want to also, the MCs were not significantly different for the 2 groups. And I also want to highlight that in other work that we did among those who continue to experience poor health-related quality of life after treatment, we observed 3 patterns among those. And we found that the first one is the sustained, where we have participants reporting depression at the start of TB treatment. And they have recurring symptoms throughout the treatment and after TB treatment. There's also a second group. So this pattern is those with new depression that's related to TB. So we see there's no report of depression at the start of TB treatment, but then there are symptoms either at the end of treatment or after completion. So this is the second pattern. The third pattern was also those who don't report depression at the start or at the end of treatment, but there are only symptoms reported 6 to 12 months after TB treatment. Now, our results from the K10, we found that there is some form of distress among the 2 groups, even after TB treatment. And also looking at the long-term economic impact of TB, our data showed that there's still severe to very severe long-term economic impact of TB in the 2 groups. So from the Sheehan Disability Scale, we see that the majority recovered socially, but we see a small, like less than 5% who continue to experience TB-related challenges in their work, family, and personal lives. So we have limitations. So our data, our results are limited by the fact that participating sites in TB sequence may not be fully representative of TB and HIV care at the national regional level. And also data collection relied on self-reported surveys, which are subject to well-established biases. And also validated instruments were administered in English. Language barriers may have affected participants' understanding of certain items. And also because the SF-12 does not assess economic burden or disease-specific symptoms, we supplemented it with additional tools to capture these dimensions. In conclusion, just want to say in this and other work, we find that a subset of TB survivors experience a decline in health-related quality of life after TB treatment completion. And at least 4 years after treatment completion, a small proportion of TB survivors experience some form of psychological distress. And of particular concern, a third of TB survivors reported ongoing financial hardship. And also, given the substantial time gap since treatment completion, there's need for further research to determine whether the reported mental health challenges and financial strain observed later are directly attributable to TB. And also from our disability scale results, we see that the majority recovered socially. However, a small minority continue to experience TB-related challenges. Thank you.
Thank you very much, Nelly. And just a reminder to people who may have joined, we will have the questions at the end. So up next, we have Dr. Juaneta Luiz, and a brief bio on her is that she is a medical doctor and a clinical researcher with an interest in childhood TB diagnostics in high TB burden settings, particularly in the context of children living with HIV, malnutrition, and the very young. She manages a pediatric TB clinical diagnostics research unit with a strong capacity development arm with the SAMRC unit on child and adolescent health at the Department of Pediatrics and Child Health at UCT under Prof. Heather Zaw. Over to you, Dr. Juaneta.
Thanks so much, Nawazi. Let me quickly try and share my screen. Please let me know if you can see the slides.
Yes, we can. Thank you so much.
Thanks. Okay, hi everyone. As mentioned, I'm Juaneta Luiz. I'm with the Department of Pediatrics and the MRC unit at UCT, but also based at Dora and Ginza Hospital here in Gqeberha. And today I'll be comparing Roche, Cobas, and Ultra on induced sputum to detect childhood pulmonary TB. Here we go, no conflicts of interest to report. Okay, so what is Roche Cobas? As some of you or many of you may know, it is a moderate complexity TB NAT, and it was conditionally recommended for the diagnosis of pulmonary TB in adults and children in 2021. However, these recommendations were based on rather limited data. In fact, at the time of recommendation, there were only 2 papers out. Currently, there are 5 papers that have been published on Roche Cobas MTB for diagnosing TB. And just to summarize them, the sensitivity and specificity are similar to that of Ultra against culture, sort of across the studies. Some of them show slightly better accuracy or improved accuracy with people living with HIV, and some show the opposite. But generally, it seems to perform similarly. However, there are no studies to date in children. None of these studies included children. As many of you may know, the Roche Cobas MTB was rolled out as the TB NAT of choice in South Africa in 2024 in many of the high throughput labs in our country. And so our aim was to compare the diagnostic accuracy of the Roche Cobas MTB with Xpert Ultra and induced sputum to detect TB in children, pulmonary TB. Right, so let's do a quick comparison between the two before we look into the results. The big benefit that Roche Cobas has is that it provides INH sensitivity in addition to rifampicin, and this is useful in our setting where we have a high prevalence of INH resistance, reported anything between 6 to 12%. However, as mentioned, Roche has not been tested on children. Unfortunately, there's no data available on limits of detection in children or yield in children. However, the reported LOD is 7.6, and Ultra, in comparison, has been extensively tested on children with as good results as you're going to get for a PCR test in children. And it's able to, there's a few studies that have actually shown that it's able to detect TB in culture negative children. And this may be because for the culture process, the TB is perhaps dying in the process from the point of collection all the way to the point of testing. Whereas, as we know, the PCR test is able to detect dead bacilli, and many children don't have previous TB to confuse that picture. The LOD is higher than that of Roche. And so we had some hope for Roche to perhaps add some benefit in this group. And then finally, to compare the lab processes, Xpert is simple. There's no actual need to have lab expertise. In fact, our study team and many study teams across the country have performed it with no lab background and just minimal training. It requires about 1 minute preparation time, which includes some shaking steps and a 15-minute incubation, and processing time is 1.5 hours to 2 hours. Roche is reported as a 2-step process, though it is rather labor intensive. It does require lab expertise, and this is actually why it was rolled out in the high throughput labs in the country. And the preparation time is about 3 minutes. That includes vortexing and a rate limiting sonication step where only 5 samples can be taken at a time, which you can imagine is an issue in a very high throughput lab. For example, in our lab, they're processing hundreds of samples a day. And then there's also a centrifugation step, altogether taking about 3 minutes, depending on the waiting time. And the incubation time is 1 hour, and processing time is 2 hours 20 to 3 hours. Okay, so in our setting, we are running a prospective observational diagnostic cohort study. We've actually been running it since 2016 at Dora and Ginza Hospital in Gqeberha. And our current inclusion criteria are listed here. The time is short, I won't go through it in detail, but we are including children under 15 years with signs and symptoms of presumptive TB. And as you can see, these are rather inclusive criteria to try and pick up the vast spectrum of pulmonary TB disease that we see in children. And we excluded children that had completed TB treatment or prevention in the past 12 months. And in a way, this is helpful because it reduces the rate of false positives amongst the TB NAT results. And also children that have taken treatment or prevention for the last 72 hours, or a follow-up or consent or assent wasn't possible. And every child was investigated as they should with all the 4 puzzle pieces to diagnose TB. And just to mention that for sampling, every child had an induced sputum performed, both by hospital and study staff, depending on when they were enrolled. The hospital has also been trained on how to perform the procedure and have been performing it for the last 9 years or so. And all the samples are routinely tested at our local national lab. Xpert Ultra was performed throughout the study period from January 2024 till April this year. But Roche Cobas came in about August, and we had more Roche samples than Xpert as time progressed. And we followed up our children quite extensively, as you can see, and that's to most accurately classify them based on the NIH consensus definitions for confirmed, unconfirmed, and unlikely TB in children. And so we derived our microbiological reference standard from those that had a positive culture. And our composite reference standard is actually all these pieces of the puzzle here. So it's those with confirmed TB on Ultra, Roche, or culture, and those with unconfirmed TB diagnosed clinically and radiologically. Okay, so let's look at the results. 213 children were consecutively enrolled in the study period. We excluded 12 where we didn't have a valid culture result on the first sample for various common reasons, and that left 201 children. And we divided them into 2 groups based on what test was performed on the first induced sputum, so as to have a fair comparison. And we had a relatively equal balance between the groups in terms of numbers. And also what's great is we had about quite similar demographic data and high-risk data between the groups, with about half of the children male, median age at around 26 months, just over 2 years, with about 50% of children under the age of 2 in both groups. Our HIV positivity was between 9 and 13% between the groups, and about 40% of children are underweight for age in our cohort, just showing the type of high-risk children that present to our facility. And just to compare the consensus definitions between the groups, you'll see that the unlikely TB groups are quite similar in terms of percentage, and that allows for a relatively fair comparison between the groups in terms of diagnostic accuracy. So let's see how they performed. What we found is that Ultra on yield on the first induced sputum far outperformed Roche with yield of 16.5% compared to 5.4%, and this was a significant comparison. And you'll notice here that actually the culture yields are similar between the two groups. In fact, Roche's is slightly higher. And the reason that for this difference is that Ultra detected 13 children that were not detected on culture, and over 3/4 of these children were trace positive, whereas Roche did not detect any children that were not detected by culture. Just to add, culture did detect 2 children that were not detected by either TB NAT test in both groups. And finally, Ultra also detected 4 children with rifampicin resistance. So that's about 22% amongst those that are confirmed, whereas Roche didn't detect any resistance in that group. Secondly, we looked at diagnostic accuracy against culture, and here we found it gets exactly the same sensitivity against culture, actually, at 71.4% between the groups. Specificity was 100% for Roche, but 87% for Ultra, but this is because we already know that Ultra detected TB in culture-negative children, which pushes down the specificity, but these children had clinical pulmonary TB disease, they improved on TB treatment, and none of them had previous TB disease. So those results, where they're ultra positive and culture negative, are probably reliable. And then finally, we looked at diagnostic accuracy against the composite reference standard, which in children is really the reference point that you want to use, or the reference standard that you want to use, given that many children are diagnosed clinically. And here we find 100% specificity for both, but this is where we really see the difference, with Ultra having a sensitivity 3 times that of Roche at 24% compared to 8%. So just to finish off, we were limited by our small sample size, and it's a single center study. And we also would have loved to test Roche, Ultra, and culture on the same sample to have the most accurate comparison. But especially in young children, sample quality and volume is generally not adequate to do all 3 tests on the same sample. In addition, we've made an application to the National Lab in July for Roche, Ultra, and culture results at a population level for all children in Gqeberha and in the Cape Town area to cover both our studies. And that's still pending, but I was hoping to have it ready for today, but it isn't, but we're still waiting for the data. Once that's out, we'll be happy to share it with a think tank as well, just to compare with our data in the study with population data and see whether we're seeing similar results. And so to conclude, overall, Ultra had a significantly higher yield in children compared to Roche, and this is because Ultra is detecting additional cases in children with culture-negative TB. And Ultra and Roche, as we saw, had similar diagnostic accuracy against culture, but Ultra sensitivity is 3 times higher than that of Roche against the composite reference standard. This is really where we want to be picking up TB, where culture would otherwise not detect TB. And so further study is, of course, required. We'd need a larger sample size. We're continuing to collect data. Multi-center collaboration would be useful. And hopefully our population level data that we've mined will also help to inform PCR testing strategies for children, which, as we can see, shouldn't always be the same as adults. And as many of us know, children are not small adults. And so perhaps we need more nuanced PCR testing strategies for this group. So just to finish up, I'd just like to say a big thank you to our participants and their families, to our clinical partners and fantastic healthcare workers at Dora Ngines Hospital and in this district, our absolutely dedicated research teams and our funding organizations, without whom none of this would be possible. Thank you very much. I'd be happy to take questions.
Thank you, Juaneta. The questions will be at the end, so just after the next 2 presenters. No problem. Thank you again. Up next, we have Prof. Denise Evans. Prof. Denise Evans is a principal researcher at HERO, who is part of the Wits Health Consortium at the University of Witwatersrand. She currently serves as a senior HIV/TB research advisor and deputy program director for HERO's Evidence Project. I will hand over to you, Prof. Evans.
Thank you. Thanks, Nwazi. Hi, everybody. Let me just share Could you let me know if you see the slide and if it's in presenter mode?
I will let you know as soon as we see it. Perhaps my view is wrong.
Just see quickly. Sorry, 1 second.
Okay. There we go.
Do you see it?
Yes,
Is
we
it
do
in
now.
presenter mode?
Yes.
Excellent, thank you. So hi everybody, and here I wanted to start off by showing you some snapshots from the Union conference, and I have let's just see if it's advancing. There we go. I have the pleasure to present on behalf of the TUTT Plus team, and this analysis was for pooling sputum specimens of people at high risk of TB. And so this was presented at a late breaker session on TB diagnostics. So just in terms of background, scaling up TB is essential, but molecular test costs do remain a barrier for programmatic implementation. And there has really been a growing emphasis on identifying simpler sample types to complement or even substitute sputum. There's also been a shift from prioritizing maximum sensitivity to maximizing access to diagnostic services. So historically, the focus was really on sensitivity or diagnostic sensitivity. However, now diagnostic yield it has become more meaningful, especially if we think about population level impact. So there are a number of publications that have demonstrated that pooling sputum samples reduces the number of tests needed without significantly affecting diagnostic accuracy. However, what we don't know is what this means for other high-risk populations, such as TUTT populations. And on the right, it's a summary of the different TUTT populations. So we have people living with HIV, those that have a self-reported contact of a TB patient in the past year, and those diagnosed with TB in the past 2 years. So we don't know what pooling looks like or how effective it is in these high-risk TUTT populations. And also, if we think about the cost, most of the reports really only focus on the costs or the savings related to the cartridges and not other direct costs or direct savings. So this study and this analysis really wanted to highlight the value of sputum pooling to reduce the number of molecular tests while maintaining full individual coverage and diagnostic accuracy. So for our objectives, the first one was to assess concordance. And so just to note here that we did not have culture results for all the individuals. And so instead of estimating sensitivity or specificity, we assess concordance between the pooled and individual Xpert Ultra results. We also then wanted to determine the optimal pool size, and last we wanted to compare the direct costs of sputum pooling versus individual testing. So in terms of our methods, I'll first walk you through the laboratory methods to estimate concordance. So this study was nested in the TUTT Plus study. So this enrolled adult outpatients at facilities between September 2024 and June 2025. From those individuals, we obtained a minimum of 2 milliliters of sputum that was collected, and this was processed as per manufacturer's guidelines. And from that, we took 500 microliters for pool sizes 4 and 5, and you can see in the diagram on the right. So we then have the processing of the sputum samples, and from that we took 500 microliters of the buffered sample, and that is pooled, you can see, into a separate tube with a blue lid on the far right. And so that was for pool sizes of 4 or 5. Where we had smaller pool sizes, for a pool size of only 3 samples, we increased the volume to 700 microliters. So this enabled us to evaluate pool sizes of 3, 4, or 5. And then the individual and the pooled samples were run concurrently, and then we did the concordance analysis, which I'll show you the results. And then just to say for concordance, how we handled trace results. And so we considered 3 different scenarios, one where the trace results were positive in the pool only, one scenario where it was positive in the pool and the individual results, and then trace was not positive in neither the pool nor the individual results. For the cost analysis, we got the results, the ultra results, as well as the characteristics from the TUTT Plus study, and we did the costing from the provider perspective. We used a combination of ingredients-based and a top-down approach, but then also used expert opinion and literature on some of the inputs, including biosafety equipment, PPE, and other laboratory equipment. We did a time in motion study at the routine lab as well as a reference laboratory. For our costing data, we used the current country price for Gene Expert. And then we used the South African public sector staff salaries for a medical technologist and a laboratory supervisor. So our aims here for the costing were to estimate the direct costs for pooling versus individual. And here we estimate, well, in the results, I'll show you the cost per person tested, as well as the cost per TB diagnosis. Just some assumptions in this analysis is that we assumed that all the results from the pooling were manually recorded and verified. We assumed that there were no changes in lab staff or equipment. And then for the costing, we assumed if it was trace or we had received an invalid result for the pool, then the individual samples were all retested. So to the results, so we had samples for over 2,500 individuals. You can see 29.3% were males with a mean age of 39.9 years. You can see the breakdown there for the different TUTT populations. So people living with HIV at 78%, TB in the past 2 years at 24%, and symptomatic 23.2%. We also show the breakdown, samples that were collected across the different provinces. So Limpopo at 26%, Western Cape 36%, and KwaZulu-Natal at 38%. On the right-hand side, just to show the distribution of the pooling sizes that we evaluated, you can see for the majority, it was a pool size of 4 at 65%, a pool size of 3 at 31%, and a pool size of 5 at only 4%. And you'll see in the results that, yeah, this was a really small number, which did limit some of the analysis. So here I present the result, which the concordance, which on the left-hand side, which is really answering our first aim. And so here we do present results for a pool size 4. So we have a similar table for pool size 3 and 5, but I'm only showing here pool size 4. And then you can see the middle column is where trace was considered positive for both the pool and the individual. And the column on the right is where trace was not considered positive for neither the pool nor the individual. Unstratified, and so this is where we just pooled, this was for all the pools. And you can see in terms of concordance that we saw the highest concordance for people living with HIV at 97.8%, highlighted in red, and also for the asymptomatic individuals at 99.5%. Just to say overall, we had an individual positivity rate of 3.82%. In terms of error rate, pooling often increases complexity. So we did get an increase in the error rates at 2.74% in the pools compared to only 0.76 in the individuals. And the errors were mainly driven by instrument error. On the right-hand side, which is the second aim, which was really to determine the optimal pool size. So from the results of the concordance, we concluded that a pool size of 4 consistently achieved the highest concordance across the groups. A pool size of 5 had reduced concordance. And then we show here that 4 was better than 3 and 3 was better than 5. And just to show you again, this is the results for the middle column there. For the symptomatics, it was 95.5% compared to 93.6% in a pool size of 3 and 84.6% in a pool size of 5. For the HIV negatives, again, 94.6% for a pool size of 4, 50 for a pool size of 3, and 83.3% for a pool size of 5. And again, a pool size of 4 outperformed a pool size of 3 for also the asymptomatics and those living with HIV. And just to say here, yeah, we could not present the results for 5 because they were really small numbers. In terms of the cost comparison, which was our objective 3, you can see the top is really, again, just repeating the total number of specimens that were tested individually, or in brackets there in that first row is the pools. And we present results for unstratified, so all pools combined, and then among those living with HIV and asymptomatic, only for pool size 4. So we also show the individual tests as well as the pooling yield, and a repeat then of the concordance that I showed on the previous slide. From the costing, what we see individually, and so you can see across all the groups, an individual cost per person tested was at $15, just over that. And then we also have the cost per person diagnosed, which ranged from $394 to just over $1,000 per person diagnosed if we tested them individually. When we used the pooling, you can see that the cost per person tested was around $6, and for the asymptomatics dropped to $5.5, and you can also see the cost per person diagnosed. Overall, we saw a cost saving of around 60% across the different groups. And just to note here that pooling works really well when there is a low TB prevalence. So we also did some work with increasing the prevalence, and there we actually saw a decrease in the cost saving. So it's actually the more negatives that you have, the better the cost saving. So it is directly linked to the pooling yield. And then just on the right-hand side to outline the cost drivers. So you can see in the results, we compared pooling versus individual. In the lab testing, the individual was slightly higher than the pooling. For staff time, this was higher in the pooling than the individual. And we also saw slightly higher, 8% in the individual compared to 7.9% for the pooling. And then we looked at how much testing and also how many positives we could get if we used the same amount of budget for pooling and for individuals. And we saw that we got 2.5 times more people could be tested with the same budget using the pooling strategy. So also then from the results, we did get some lessons learned from the laboratory implementation experience. So there were some limitations in terms of how many batches or pools could be processed in a work cycle. It was also quite difficult to do the pool assignment based on HIV status and symptom stratification. However, the laboratories were able to implement a worksheet-based system into the lab information system, which also then improved traceability and reduced manual error. Also, contamination risk is a consideration, but we did not observe this in the study, and this really demonstrated feasibility with proper training. One consideration also is just that this study used or relied on Xpert Ultra. That may limit scalability, and so there is a need then to look at other platforms for wider implementation. So in conclusion, what we do find is that ultra testing used in these pooled sputum specimens is cost-effective, accurate strategy for TB diagnosis in this TUTT high-risk adult population. And just to highlight here, this again was a facility-based. The recommended pool size was 4 for people living with HIV or asymptomatic individuals. And pooling can significantly increase TB testing capacity and reduce costs. However, there are some laboratory considerations, and it could be this approach could facilitate scalable TB testing in resource-limited settings. So the team is busy engaging with stakeholders, as well as trying to plot or figure out the next steps and what are the gaps in data that are needed, and where do we go from here. So this is just an acknowledgement to everyone involved. It's a big piece of work with a number of partners and a number of moving parts, and so just to acknowledge the funders and all the partners involved. And that's the end. Thank you.
Thank you, Denise. And our last speaker for this afternoon, we have Dr. Mmamapudi Kubjane. Dr. Kubjane is an epidemiologist and a mathematical modeler based at HERO as well. Her work focuses on assessing the epidemiological impact and conducting economic evaluations of TB programmatic interventions in South Africa. Over to you, Mmamapudi.
Oh, sorry.
No problem, I was done.
Okay, let me share my screen. Okay, is it visible in?
Yes, it is.
Present the mood? Okay.
Yes, now it is.
Okay, thank you for the introduction and opportunity to present this work here, and greetings to everyone. So I'll be presenting some of the work that we did on estimating the epidemiological impact of the TB and HIV funding cuts that we have heard about throughout from the earlier this year. And this was an effort with HERO and some partners from the TB think tank here and from the TB program. So as we all know, South Africa has made considerable progress in controlling TB, and largely through investing in testing, as we've had a lot of talks on diagnostics, and also expanding treatment and the scale up of ART as well. However, we still have a high burden of TB, which is largely driven by HIV, and also have high rates of drug-resistant TB. And in terms of the funding landscape, the South African TB program is largely funded domestically, with about 2/3 of the program funded through local sources, and the Global Fund contributing around 19%, and USAID and PEPFAR contributing 14%. And so the stop orders that we had and the cessation of some of the programs that were funded by the PEPFAR and USAID is threatening the progress that we have made to date. So the main objective of this work was to assess the impact, the potential impact of these funding cuts on TB incidence and mortality between 2025 and 2035. And additionally, we assessed the impact of the funding cut scenarios, which I'll describe in a few slides, on the TB program costs. So we did this analysis using the Tembisa TB model, which is a compartmental deterministic model that simulates the South African TB and HIV epidemics over time, and also includes TB interventions and HIV interventions. Some of the interventions in the model include preventative therapy, testing and screening, and treatments for TB. For HIV, we include prevention, testing services, and ART. The model integrates how HIV increases your risk of developing TB disease and mortality as well. The model is also integrated with the South African TB program cost, which are informed by primary studies using ingredient-based approach and also informed by the literature. And all costs are from the provider's perspective. So at the time we did this analysis, there was not enough information about how specific interventions would be affected by the funding cuts. So we then convened a small group of experts, of TB experts in South Africa. So from the TB program, some from the implementers, researchers, and also some coming from the TB think tank here, to give us their best guesses or assumptions on how the interventions coverages would be affected. So for instance, for prevention testing, we gathered that the reductions could be about 20% at minimum and about 25% at maximum. And for HIV, we relied on another earlier analyses that looked at the potential impact of the HIV, of the funding cuts on HIV. So the main assumption was on ART coverage reductions. So we, in that scenario, we considered a 14% increase and a 28% increase. And in addition to these, we added scenarios where we assume that there would be a recovery scenario from 2028 onwards, so meaning that we sustain these reductions from 2025 to 2028 and then recover or return to baseline levels. And then we also added a no recovery scenario, which is having no recovery of the intervention. So we sustain the intervention reductions over time. And we compare these with a baseline scenario of no funding cut, of no funding cuts. So overall, we modeled these scenarios, 4 scenarios. So minimum reductions with and without recovery, and a maximum reductions with and without recovery, and combining all HIV and the HIV and TB interventions. Okay, so this is the facet of the results showing the impact of ART coverage reductions on HIV infections. As we could see, in the maximum scenario, maximum scenarios without recovery, we estimated that we could have additional, between 2025 and 2035, we can have additional million new infections of HIV, which is about 67% increase relative to a baseline. And in the minimum scenario could be around 230,000. And as we know, HIV increases susceptibility to TB, and also so that leads to HIV-associated incidence and mortality. So we estimated that these funding cuts for HIV could also lead to increases in TB among people with HIV by 12% to about 41% for TB incidence, and mortality could increase by 21 to about 72% in people with HIV. And with regards to TB incidence in the general population, as we could see in this figure, under the maximum scenarios without recovery, this could set us back a couple of years back in terms of the progress that we have made. And even if we do have recovery, it will take a couple of a decade or so to get back to recovery, if we do to get back to the baseline trend, if there's nothing, if there is any measures taken to recover these funding cuts. And overall, in these scenarios, we estimated that in the minimum scenario, in the minimum with recovery, we can have additional 220,000 TB cases, which is about 7% increase relative to our baseline, to an increase to in the maximum we can have around 730,000 new cases, which is around 24% increase relative to a baseline. Similarly with mortality, this will set us back a couple of years back. And if we do have any recoveries, it will take about 10 plus years to return to the baseline. And the estimated increases in TB deaths overall in the minimum scenario was about 67,000, which is about 14% increase relative to a baseline without any funding cuts. And in the maximum scenario with the funding cuts, no recovered, we can have an additional 225,000 deaths, which is about 47% increase. So these figures just show the total program costs under these different funding cut scenarios we just described, without constraining anything. What we know is that major cost drivers in South Africa are testing, followed by treatment for both drug-resistant and drug-susceptible TB. But when we look at the different scenarios, in the funding cut scenarios with no recovery, the costs seem to be low. But when we look lower than in the baseline and the recovery scenarios, but if we look further into the treatment specific costs, over time, they actually continue to increase, especially in the non-recovery scenarios over time. And this is just a reflection of an increase in the burden of TB and the people who require treatment. So over time, there will be a large number of people who would require treatment, and that is also which is requiring a lot of investment in funding. So some of the limitations in our analyses is that we did not explicitly model everything that was affected by the funding cuts, such as the impact on the general health systems and data quality and data capturing and technical support that the Department of, or the TB program was receiving from the PEPFAR USAID. Also, we do acknowledge that the PEPFAR and USAID supported specific districts in the country, but for our model, we were assuming these were at a national level. And overall, throughout the analysis, we are assuming that there is a replenishment of the global fund, which is not actually given. I'm actually not aware if, or I don't know if it was renewed for the next round. And also, we don't take into account that the National TB Program actually is carrying on with the 5 million tests campaign, which is an important factor to account for. And also, we know that there were additional funds that were committed to HIV at least, but by PEPFAR, but we don't know how much is allocated for TB yet. But overall, with the available information and best assumptions that we could make, we were able to provide estimates of what could happen in South Africa if we do not close the gap in funding for the TB program. So it could, as we could see, there will be a large number of TB cases and mortality estimated. We estimated a substantial number of TB cases and mortality due to the funding cuts, and that is just to plea for to find means to close the gaps through local and with international funders. And with that, I would like to thank the colleagues from HERO and those who are involved in the work and our funder. Thank you.
Thank you so much, Mmamapudi. Thanks to all our presenters. I am aware of the time, so if we could just quickly move on to our questions. I've just allowed mic for attendees. Please raise your hand or just unmute and ask your question or pose a comment to the presenters. Please also specify who the question is for. Any questions, comments? Pren, you may go ahead.
Yes, thanks, Nolowazi. So thanks for the great presentations, colleagues. I just wonder, I mean, the evidence from the pooling study is quite compelling. What do you think it will take to get this translated into policy?
Thanks, Pren. I wonder, I think Prof. Martinson is on the call. I wonder if he is able to respond. I mean, we have been in some discussions about what it would take. And I think the suggestion is to kind of do targeted pooling based on prevalence, so certain settings where it may work better. So settings or certain populations, like we showed, the asymptomatic or people living with HIV. But I wonder if Prof. Martinson wants to just comment on the next steps and kind of give a summary of those discussions and where we go to from here. Prof, are you able to comment?
Yes, I can. I just so just very briefly, we have been in discussions with both NICD, where the actual work was done, as well as with senior members of the TB program, as well as with the NHLS. And there are some obstacles in getting this rolled out. There is a contract with these providers that I think lasts another 2 or 3 years. I'm not sure if the contract includes this idea of pooling, so there are some administrative things. The next thing is that the most benefit will be experienced in high volume labs, and our study was done with Ultra, and as Denise pointed out, it hasn't been validated on Roche. So our proposal is to request if we could do a pooling pilot where we replicate the study that we have just completed in pools of 4 using Roche, though, rather than Ultra, and maybe do it in 1 or 2 sites where the Roche Cobas is being used currently. So I think we would really like to realize some of these savings. And interestingly, another study at the conference showed very similar savings to what we had with pools of 4. So I think it is appropriate that we go forward, but we go forward cautiously. Thank you.
Thank you, Prof. And thank you, Pren, for your question. Any other questions or comments? There's someone who is unmuted right now. Any questions, comments, colleagues, for our presenters? And also just a quick reminder that if you'd like to present next year on this platform, you can email myself at ngosi@tbthinktank.org. Okay, Pray, you may go ahead.
Sorry, since nobody else is making a comment on this, I mean the yield in children comparing Xpert and Roche was, really, really surprising. I mean, I've seen small percentage point differences, but a 3-fold difference I haven't ever seen before. And I find the results quite shocking, actually, particularly when we have transitioned many of our labs to Roche. And I think this is something that, really does need to be flagged. It's a source of grave concern.
Thanks so much. I just want to add to that. Yeah, I just replied on the chat as well. I mean, our sample is rather small, relatively small, and it is a single center. So I think I was hoping to have the results ready or the data sent to us from NHLS for the population level results. Once we have that ready, we'd be happy to share that with the think tank. And if the pattern is similar between our study and if there aren't any biases we've missed, then we would start to look into why these differences are occurring. Perhaps there's something that differs between the tests in terms of their CT thresholds, and we'll look at differences between semi-quant results and CT values. But it is concerning, and I think like what our data shows is that we should just maybe just take a pause and think about it, and that perhaps we can't use the same recommendations that we'd make for adults based on adult data and extrapolate them to children across the board. So we'll be in touch with the population level data, and we'll continue to collect data at our site as well. Hopefully it isn't as bad as it looks, but we'll work on it and see and communicate further. But thank you so much.
Thank you, Pren and Juaneta. I think in the absence of any more questions, we can end the session. And I'd just like to express my gratitude to our presenters today. Thank you to all of you. And thanks again to our attendees. Thanks for your time and your questions and comments throughout the year. This is the last webinar for the year from the TB Think Tank. And we'll see you again in the new year. Please do enjoy your festive and stay safe. Thank you so much.
Thanks, colleagues.
Thanks, everyone.